better, nah?
Yeah, now it's better, doctor.
Okay. All right. So, okay. Is this the first time I'm giving lecture to you?
Yes, doctor.
Oh, okay. So there are 25 of you in the class. This is a very small number, isn't it?
Yes, doctor.
Okay, never mind. So there will be a series of lecture that will be given by me in this few months' time. So I will start with the maxillary sinus lah. Yeah. All right. So I have uploaded the slides last night. Did you notice it? It's
Yes,
in the
doctor.
e-portal.
Yeah, it's
All right. Okay. Okay. All right. Okay. So today's lecture will be on what we call maxillary sinus. See whether I can. All right. This is share screen. Share screen. Okay. Okay. Can you? Can you hear me? Can you hear me or not?
doctor. Your line is breaking, doctor.
I think it's the internet issue. Hang on, Okay. All right. Can you see my slides?
Yes, doctor.
All right. Okay, let's start the ball rolling. So the first lecture today will be on maxillary sinus. I think every one of you have heard about maxillary sinus. Okay, Larissa, are you around?
Yes.
Okay. How many sinus do we have in the region?
5, I guess.
5. Okay, never mind. You get the answer. Okay, excellent. All right. Razina, are you there? Razina? Okay, Haley, are you there?
Yes, doctor.
Okay. What is the nerve supply for maxillary sinus? Just a quick one. Just want to check.
Maxillary nerve.
Okay, good. I just want to check how much you know about maxillary sinus lah. Yeah, and last question, Nurul Aqua. Are you there?
Yes, doctor. Yes, doctor.
Okay. Yeah. What is the major blood supply for maxillary sinus?
Um, is it the maxillary artery?
Okay, that's good. All right, never mind. We will discuss about this throughout the lecture. Right. So today's lecture will be on maxillary sinus. So this is the learning outcome of this lecture. So we'll be talking about the introduction, the anatomy of the maxillary sinus, the development process of the maxillary sinus, neurovascular blood supply and neurovascular supply, and also any pathological changes and how do we manage all these pathological changes. All right. So, okay, there are actually four what we call sinuses around the facial region. These are called paranasal sinus. So, paranasal sinus are the air-filled mucosa line cavities, which develops in the cranial and facial bone. These are the spaces which communicate with the nasal airway. All right, and they form the various boundaries of the nasal cavity. And the paranasal sinuses are maxillary sinus, frontal sinus, sphenoidal air sinus, and also ethmoidal air sinus. So there are four of them: maxillary, frontal, ethmoidal, and sphenoidal air sinus. Right. These are the sinuses that I mentioned before. You have the frontal sinus at the frontal bone area. Then you have maxillary sinus in the maxillary bone, ethmoidal air sinus, and then at the most posterior region, you have the sphenoidal air sinus. All right, okay. Our discussion today only will be on maxillary sinus. So maxillary sinus, also known as what we call antrum of Highmore. That is the other name of maxillary sinus. This is a pneumatic space that is lodged inside the body of the maxilla and communicates with the environment by way of the middle meatus and the nasal vestibule. Maxillary sinus was first described by Highmore in 1651. And it is the first paranasal sinus to develop. Remember that, the first paranasal sinus to develop. So it starts to grow as a shallow groove on the medial aspect of the maxilla during the 4th month of intrauterine life. And the expansion occurs more rapidly until all the permanent teeth have erupted. So the eruption of the permanent teeth basically stopped the expansion of the maxillary sinus. So maxillary sinus reach the maximum size around the age of 18 years. And the growth pattern includes in the vertical, horizontal, and anterior posterior direction. So it grows vertically, horizontally, and also anterior posterior direction. So maxillary sinus shows biphasic growth. The first growth phase occurs during the first 3 years of life, and the next growth phase occurs during the age of 17, the age of 7 to 18 years. So maxillary sinus initially located medial to the orbit, and as you grow up, it become more expanded laterally and inferiorly. And one thing that you have to remember, the floor of the sinus does not extend below the level of the nasal cavity until the eruption of the permanent tooth. So before eruption of the permanent tooth, the floor is above the level of the nasal cavity. Right, so this is the 8 changes during the development of the what we call the maxillary sinus. So during the first 3 years, the maxillary sinus developed in the form of ovoid. It developed in the form of ovoid. So the volume is about 6 to 8 mil, very small volume. As you grow up, the width increase, it starts to expand, and the volume also will increase. See, at the age of 7 to 9 years old, the volume increases to 10 to 12 mil, right? And then at the age of 9 to 12 years, it assumed the pyramidal shape. From ovoid, it assumed the pyramidal shape. Okay, and the volume increases to 15 to 20 cc at the age of 12 to 18 years age, right? And as you grow older, and if you have your tooth extracted, there will be resorption of the alveolar ridge. So when there is resorption of the alveolar ridge, there will be thinning of the sinus wall. So if you see in the elderly patient, the sinus will look bigger. Why it looks bigger? Because there is no tooth around the area, because most of the tooth has been extracted. So there will be resorption of the alveolar ridge. So this is what we call sinus pneumatization. You will see in the lecture later, as you grow older, and if you have the tooth extracted, as time goes by, you will see the sinus become very big. But the volume of the sinus will be maximum 20 cc. That is the average volume. All right. So when we look at the structure, maxillary sinus is a four-sided pyramidal structure. The base is facing medially toward the nasal cavity. If you imagine the maxillary sinus as a pyramid, the base will be facing the nasal cavity medially, and the apex will be pointed laterally towards the body of the zygoma. If you can imagine the maxillary sinus as a pyramid, the base will be facing medially towards the nasal cavity, and the apex will be pointing toward the body of zygoma. Right. So you have anterior wall, inferior, superior, and posterior wall of the maxillary sinus. So if you look here, you can see it looks like a pyramid. So this base is facing towards the nasal cavity, and the apex is facing toward the body of the zygoma. Then you have the superior wall, which form the floor of the orbit, and the inferior wall, which form the alveolar process. Right. So the medial wall forms by the lateral nasal wall. So you have it developed below. You have the inferior nasal conchae, and behind it bounded by the palatine bone, and above is bounded by the uncinate process of the ethmoidal bone and also the lacrimal bone. All right. So the base is the thinnest wall. The base of the maxillary sinus is the thinnest wall. So there you have perforation, the opening of the maxillary sinus, what we call the ostium. And the opening of the maxillary sinus is at the middle meatus, and this is known as hiatus semilunaris. If you look at the middle wall of the base of the maxillary sinus, you will see the opening at the middle meatus, and the opening is known as hiatus semilunaris. Okay, so as mentioned, the opening of the maxillary sinus is called ostium. Okay, is open at the hiatus semilunaris, and the level of the opening is just above the nasal of the nasal floor. So meaning the opening of the maxillary sinus is quite high up. So that is the reason why the maxillary sinus is the most common sinus to get infected, because for the whole fluid in the sinus to be completely drainage, in the infected cases, it will be very difficult. Why? Because the opening of the maxillary sinus is at the level of the nasal floor. Okay, so remember, maxillary sinus is the most common sinus to get infected. All right. Okay, then we have the superior wall. The superior wall actually forms the roof, the floor of the orbit. The superior form the floor of the orbit. The medial wall form the lateral nasal wall. Okay, and the superior wall forms the floor of the orbit. So the important structure in this particular region are the infraorbital canal, the infraorbital foramen, and you have the infraorbital nerve and the infraorbital vessel. So the posterolateral wall of the maxillary sinus, this is made up of zygomatic and greater wing of the sphenoid bone. The posterolateral wall is thick laterally, but is thin medially. So the important structure in this particular region, you have posterosuperior alveolar nerve, maxillary artery, trigopalatine ganglion, and also nerve of the trigoid canal. And the last boundary of the maxillary sinus is the anterior wall. This extends from the piriform aperture anteriorly to the zygomatico-maxillary suture and inferior orbital rim superiorly to the alveolar process inferiorly. So the thinnest part of the anterior wall lies at the canine fossa. The area at the canine fossa is very thin. That is why when you are doing a surgical procedure known as Cartwell lock, where you want to explore the antrum, you always make the bony cut at this particular region. Why? Because the bone is very thin. All right. Okay. So the important structure in this particular region are the infraorbital foramen, the anterior superior alveolar nerve, and also the medial superior alveolar nerve. Right. Now let's look at the floor of the sinus. The floor is formed by the junction of anterior sinus wall and the lateral nasal wall. It has a close relationship. There is a close relationship between the maxillary sinus and the root of the tooth, right? So especially true for the posterior teeth, because the posterior teeth has a very close relationship to the maxillary sinus. That's why in some cases you can see pathological changes easily occurs at the posterior aspect of the jaw, of the upper jaw. Right. So the blood supply actually comes from the third part of the maxillary artery. You know that the maxillary artery can be divided into three parts. The first part that runs behind the condyle. The second part just entered the lateral trigoid muscle, and the third part, this is where it travels anterior to the lateral trigoid muscle and it enters superiorly to the posterior part of the maxilla. So the branches of the third part of the maxillary artery are the one that supply the maxillary sinus. All right. So these are the posterior superior alveolar artery, the infraorbital artery, and also the greater palatine artery. Give me 1 second. I have a phone call. Hello. Ya, cakap. Boleh. Saya tengah bagi lecture. Nanti dalam pukul 9 saya datang jumpa Cik Hai. Oh, 9. Oh, sorry, pukul 9. Pukul 10 saya datang jumpa Cik Hai. Nah? Okey, baik. Okey, baik. Okey, terima kasih. Oh, sorry for the disruption. All right. Okay. The venous blood supply come from the anterior facial vein, the sphenopalatine vein, and also the tragus plexus. So remember, the arterial blood supply come from the maxillary artery. The venous blood supply come from the facial vein. You have anterior facial vein, the sphenopalatine, and also the tragus plexus. The nerve blood supply, the sensory blood supply for the maxillary sinus actually come from the maxillary division of the trigeminal nerve. This is where you have the infraorbital nerve, which also supply the lateral aspect of the nose, the infraorbital area, and also the upper lip. And then you have the posterior, middle, anterior, superior alveolar nerve, and also the greater and lesser palatine nerve. Lymphatic drainage, the lymphatic drainage of the sinus is through the network that serve the nasopharynx or the submandibular lymph nodes. Right. Now let's look a bit at the histology of the maxillary sinus. The sinus is lined by three layers. You have the epithelial layer, the basal lamina, and the subepithelial layer with periosteum. So the epithelial is pseudostratified, columnar, and ciliated. So it's very important to remember that the ciliated pseudostratified columnar epithelial allow the movement of mucus in the maxillary sinus towards the opening of the hiatus semilunaris. All right. Okay. So the lining consists of three layers: an epithelial covering, a lamina propria, and the periosteum. So the thickness of these three layers is not less than 1 millimeter. So it's very, very thin. So if you look here, you have epithelial layer, you have the goblet cell, which produce the mucus, and you see the pseudo-stratified columnar epithelial cell. So when you have the mucus being secreted, it will be moved by the movement of the cilia, and then it allow the drainage of the what you call secretion in the maxillary sinus, right? So the lamina propria is the thin layer of connective tissue. So this is very thin. It's thinner than the nasal mucosa. So it contains fewer mucus, seromucus, and serous gland. So the secretion from this gland is actually controlled by the division of autonomic nervous system. All right. Okay. The periosteum. This periosteum is adhered to the overlying lamina propria, so it can be stripped easily from underlying bone. So the periosteum of the maxillary sinus is very prone to edematous swelling, even on slight irritation. That's why when you have infection from the posterior upper teeth, you will see, if you take x-rays, you will see there will be swelling of the posterior, swelling of the periosteal part of the maxillary sinus. So what is the function of maxillary sinus? One is to humidify and warm the inspired air. Second is increase surface area for olfaction. Then it lightening the cycle. It lighten the cycle. Otherwise, if you don't have sinus, the skull, it will lighten the skull. If you don't have sinuses, the skull will be very heavy. And it's allow resonance of voice. It absorbs shock, and also it's contribute to the facial growth. Okay, that's why any injury at the early age of life can contribute to facial deformity, right? And then another function, important function of maxillary sinus is the production of bactericidal lysosome to the nasal cavity, right? Okay, so if you have a case where you suspected any changes or any inflammation or any pathological changes, how do you go about with your clinical examination? Right, of course, with all clinical examination, history is very important. So you have to get a good history, right? Okay, so need to ask all related question, right? Then you proceed with your inspection, palpation, then you evaluate the nasal package, see whether there is any blockage, any foul smell from the nasal area. Palpation, when you palpate, is there any tenderness at the anterior wall of the maxilla, or anterior wall of the maxillary sinus? When you inspect, you see whether there is any changes in the symmetricality of both sides. Is there any deformity, obvious deformity noted, right? And then you can also arrange for transillumination, and of course radiographic examination is one of the major tool of clinical examination, right? So this is how you do your inspection. You should be standing in front of the patient, look at the face, assess the symmetricality of the face, look at whether the face is symmetrical or not, and then look at the color of the overlying skin. This is very important because any inflammation or any pathological changes usually will clinically presented with changes at the overlying skin. Either it's become very inflamed, very reddish because of the inflammatory process, or the skin look very tan or very different from other part of the body. All right. So when you do your palpation, you have to apply a bit of pressure. Apply a bit of pressure on the anterior wall, and then run your finger along all the border of the maxillary sinus. So feel for tenderness, feel for any swelling and expansion, feel for any deformity or depression. Okay. Right. So examination of the nasal passage. This is where you can use your mouth mirror to see for any blockage of the airway. Put the mouth mirror below the nostril and ask the patient to blow air, and then you can see moisture on the mirror. Right. That's how you check for nasal patency. Checks for any foul smell, because foul smell can indicate past discharge. All right. And then, of course, you will check for any evidence of nasal polyp and any changes in the color of the nasal mucosa. Right. This is a trans-illumination test. You will need to use a special lighting system to trans-illuminate the area. All right. Okay. Radiographic examination. This is a major tool in our examination for maxillary sinus pathology. Right. The simplest one is to do a periapical X-ray. This is where you can see any changes at the apical part of the root of the tooth. Because you know the posterior teeth, they have a very close relationship to the maxillary sinus. Okay, so if you, for example, you have a fractured tooth, fractured tooth 6, you try to extract the tooth, there's a fractured root. So take a periapical, then you can see whether the root is in the antrum or is underneath the sinus lining, right? Okay, you can also send for occlusal X-ray. A true occlusal X-ray will give a good view of any pathological changes at the maxillary sinus. You can also send for lateral occlusal view. All right. Okay. So if you take a PA, periapical view, you can see like a radio opaque wall. This is what we call septa. So this septa in the maxillary sinus give a compartmentalized appearance to the sinus. Usually you will see about 3 septa, 1, 2, 3. Yeah. So you see how close is the relationship of the apex to the root. So any pathological changes, the sinus will be affected. Any fracture root and you try to retrieve the root and suddenly you push the root into the antrum, you will see when you take a periapical view. All right. Extraoral X-rays, the most common one that we request is OPG, autopanthomogram, and also OM view or Waters view. Right? So this is OPG. This is what we call Waters view. Right? You can also send for submental-vertex, but a clearer view of sinus will be Waters view or occipitomental. Right? So it gives a good view of the whole sinus, and you can make a comparison of both sinus. You can see whether the volume is basically the same or not. You can see whether there is any fluid in the cavity. For example, if you have a trauma case, if you see there is radio opacity in the sinus, meaning there is accumulation of blood clot. So that will be an indication of a fracture, right? So this is what we call Waters view. Okay, so you can see here, maxillary sinus, this is normal. A normal maxillary sinus will look very blackish, very darkish. So it's more radiolucent. But here, you can see a radio opaque. Here you can see a radio opaque features, which indicate a fluid level. Right. So this shows there is increase in fluid level in this particular area, or it can also indicate any pathological changes in this right maxillary sinus region. So that is why Waters view or occipitomental view is very important for the examination of maxillary sinus. This is OPG. So it gives also a good view of the sinus. This is the nasal cavity, and this is the maxillary sinus. So that is the medial wall of the maxillary sinus. Then you see how close the relationship of the upper posterior root with the maxillary sinus. Right. This is what we call CT scan. So CT scan is a very good tool for assessment of any pathological changes in the maxillary sinus. So if you look at the coronal view of the maxillary sinus, you can see this is the normal side. It's an empty space, and this is the pathological side. You can see a radio opaque matter in this right maxillary sinus. Okay, another view. You can see pathology here. In this case, this is what we call maxillary sinusitis. Right. So other special radiographic investigation include CT scan, MRI, ultrasound, and endoscopy. So these are the investigations tool for the assessment of maxillary sinus. So what is the clinical consideration of the maxillary sinus? What are the clinical implications of maxillary sinus? One, we look at the proximity of the sinus to the root of the tooth. We also look at the congenital abnormalities. We will discuss on the inflammatory disease, the cyst and odontogenic infection, bone tumor, neoplasia, trauma, and implant. So these are all clinical consideration that you have to think when you are dealing with maxillary sinus. So first look at the proximity with the root of the posterior teeth, especially the first molar root. So when you think about it, any infection from the tooth can easily spread to the maxillary antrum. Okay, so that is one, dental infection. Okay, then the second thing is traumatic extraction. Any traumatic extraction of the maxillary teeth can cause oro-antral communication. So that's why when you extract a tooth, then suddenly you fracture the tooth. Don't simply rush and try to retrieve the tooth. Send for a periapical view first. See whether the tooth is still in the socket or it has gone into the antrum. Because sometimes the tooth is just underneath the lining of the maxillary sinus. It's not even into the antrum yet. Unless you have perforated the antrum, it will go into the antrum. All right. So, and then if you try to use your elevator, sometimes you create a communication. And this is what we call oro-antral communication. All right. Okay. Then infection from the root of the molar can also cause sinusitis. Right? So one of the major cause of sinusitis is tooth infection. Right? So this is the important in terms of relationship of the root with the maxillary sinus. So always remember, it can cause dental infection, it can cause oro-antral communication, the root can be displaced into the antrum, and then also it can lead to the formation of maxillary sinusitis. Right. Okay. Look at this PA, periapical view. You can see grossly carious tooth. You can see here. You can see radiolucency at the periapical area. So all this infection can spread into the maxillary sinus. And if you try to retrieve a fractured root, for example, if you accidentally push your instrument into the sinus, the root may go into the maxillary antrum. Right? You see again, the PA, how close is the tip of the root to the lining of the sinus. So usually when you look at the periapical view, you will see a thickening of the sinus mucosa at the infected area. That is a normal body reaction. Normal body reaction to any apical infection, any infection from the tooth. Right, here you have what we call oro-antral communication, meaning communication from the oral cavity into the antrum. Okay, here you can see a communication there. So food, fluid, it can goes into the antrum. Right. Okay, then look at the congenital abnormalities. What are the congenital anomalies related to maxillary sinus? You can think about agenesis, aplasia, or hypoplasia. Underdeveloped what you call maxillary sinus. You may have the cleft palate. The cleft palate. In patients with cleft palate, usually they will have a issue with maxillary sinus. And then there is a condition known as pituitary gigantism, which is also related to congenital anomalies of the maxillary sinus. Okay, inflammatory disease related to maxillary sinus, basically bacterial infection, fungal infection, and also viral infection. Bacterial infection is the most common infection related to maxillary sinus. All right, okay. What are the cysts or tumor that is commonly related to maxillary sinus? Okay, you have odontogenic and non-odontogenic cysts, and also odontogenic and non-odontogenic tumor. All right, odontogenic cysts, for example, you may have radicular cysts, residual, dentigerous, and primordial cysts. Non-odontogenic cysts, you may have mucocele and retention cysts. Odontogenic tumors, most common one is ameloblastoma. Right. So here, if you look at the scan, this is a coronal view. You will see at the right maxillary sinus area, you can see radial opacity of the sinus, and you have a tooth there, and this is a condition known as dentigerous cyst. All right. You may even have what we call mucus retention cyst. See how the mucus retention cyst can cause expansion of the sinus. This is the normal side. That is the pathological side. You see how the sinus can get expanded by the pathological process. Here is what we call ameloblastoma. Okay, so ameloblastoma is an odontogenic tumor, right? So it can cause a bony destruction to the maxillary sinus. All right. Okay, this is what we call squamous cell carcinoma. This is a malignant tumor. Ameloblastoma is benign. Squamous cell carcinoma is a malignant tumor. This is a very destructive tumor. You can see the whole maxillary sinus has involved, and it has eroded into the nasal cavity and also into the orbital cavity. So this is a very serious condition. Okay. Now, what are the bone tumor related to maxillary sinus? Okay, you can talk about fibrous dysplasia, ossifying fibroma, and also osteoma. These are tumors that can occur in maxillary sinus. Okay, neoplasia, neoplasm. Okay, as I mentioned before, you may have squamous cell carcinoma. It's a malignant tumor. You may have adenocarcinoma, which is related to salivary gland. You may have what you call osteosarcoma and also Ewing sarcoma. Trauma also is very important in maxillary sinus, in relation to maxillary sinus, because any injury to the maxillary sinus, it will cause bony deformity, it will cause bleeding in the sinus, it will cause structural and functional disturbance to the surrounding area. Okay, so trauma, it can cause fracture to the tuberosity, it can cause fracture to the dental-alveolar region. I think maybe you have heard about Lefort fractures, where you have Lefort 1, Lefort 2, Lefort 3. So Lefort 1 is where you have fracture of the maxilla at the tooth-bearing area only. Lefort 2 is where you have a pyramidal fracture, and Lefort 3 is where the whole maxilla and the face is floating. It becomes dissociated from the cranial base. Okay, so trauma of the zygomatic complex fracture also will affect the maxillary sinus. Okay, it will affect the maxillary sinus. Orbital floor fracture also will affect the maxillary sinus. Remember, the superior wall of the maxillary sinus forms the orbital floor. So if there is a fracture involving the maxilla, or involving the zygomatic complex fracture, or involving the Lefort 2 fracture, it will also involve the orbital floor. Okay, so trauma also can lead to the formation of oroantral fistula. Sometimes you have a fracture of the dental-alveolar region of the maxillary area. So that part has not been treated properly. You may have a communication. So this communication will end up become a fistula. Right. Remember, I mentioned the words maxillary sinus pneumatization. So as you age, when you have a tooth extracted, you see the lining will be the lining of the sinus will go more inferiorly. So the whole sinus is become expanded. So this is what we call sinus pneumatization. So this can cause problem when you want to put an implant. Why? Because you see how much bone is left there. So you may need to do what we call a sinus lift procedure, and you need to place bone graft into this particular area before you can surgically place an implant, right? So sinus pneumatization can cause problem to placement of implant, okay? And it can also predispose this area to a dental-alveolar fracture. If you have a motor vehicle injury, for example, this part of the area can easily get fracture. Okay, so that is maxillary sinus pneumatization. So the last thing that you need to think about when you're talking about maxillary sinus is the use of implant in restoring a missing tooth. So if you remember this, I mentioned just now, when you have sinus pneumatization, the sinus become expanded inferiorly, so there will be less bone at the alveolar region. So in order to put an implant, you need to add up bone there. So you can either use autogenous bone graft or alloplastic bone graft, right? So implant placement, you need a proper planning. So for the case just now, you need to plan placement of bone graft before you go ahead with placing an implant into the particular area. Okay, so this is where you need to do a sinus lift procedure. And if you remember, I mentioned just now a Capwell lock procedure. This is where you make an opening at the canine fossa at the most thinnest part. So you create a hole, you lift, and then create a hole, and then you lift up the sinus lining, then you can pack bone in that particular region. So this is what we call a sinus lift procedure. Okay, so this is how we do a sinus lift. You see, you have a very thin bone here with sinus pneumatization. So you can do a Capwell lock procedure. You make an incision at the sulcus of the upper posterior region. Okay, you raise the flap, expose the anterior wall of the maxilla. Remember, I tell you the thinnest part at the anterior wall of the maxilla is at the canine fossa. So you can cut a hole there, you can make a hole there, a window, then you can insert your instrument, elevate the sinus lining. Then you can pack your bone, into the area. So as a result, you will see from a very thin bone, so it become thicker. Then you can place your implant. Okay? All right. So sinus lift procedure, you have many techniques. You can have what you call extra-alveolar technique. This is extra-alveolar, or you can go through the socket. Okay? But don't worry about this. We will discuss this in the future. All right. So how do we manage any pathology in the maxillary sinus? Okay, for example, you have oro-antral communication. You have to treat the oro-antral communication. Why? Because if not, fluid will go inside the antrum. There will be foul smell. Speech will be affected. Patient cannot use straw. Because you cannot suck fluid from the straw. Because there is a communication from oral cavity to the antrum. So you need to close the oro-antral communication. How do we close it? Okay, how do we manage it? There are many ways of doing things. You can use a flap or you can use a prosthesis. Okay, so what type of flap that you can use? You can use a buccal advancement flap. You can use a palatal rotational flap. Buccal advancement flap is where you make an incision at your buccal aspect of the area. You can make a triangular flap, and then you can raise the flap. You can advance the flap. Okay, and palatal rotational flap. This is based on the greater palatine artery. You can raise a tongue-like flap, and then you can rotate the flap and cover the defect. Okay, you can also use tongue flap. You can also use the dorsal aspect of the tongue, and then you can raise it and then close the flap. And then after a period of time, usually after 2 weeks, you can cut the pedicle. The pedicle is very important for the first 2 weeks for blood supply to the area. After 2 weeks, you can cut the pedicle, and then the communication will be closed. And you can also use the buccal pad of fat. Because the buccal pad of fat is supplied by the buccal artery. So this buccal pad of fat can be used. You can pull the flap and you can cover the defect. And then that area will epithelialize. The fat will transform into an epithelial cell. Then it will form the normal mucosa. All right. So prosthesis, you can also use prosthesis. And you can use a palatal prosthesis, but then usually patient cannot tolerate prosthesis. But this is one of the procedure that you can use. Okay. if you have a cyst in the antrum, what can you do? Okay, you can marsupialize the cyst, you can enucleate it, or you can do primary marsupialization and followed by secondary enucleation. Marsupialization meaning you have a big cyst, you create a window, okay, expose the lining, cut the lining, then you suture the lining of the cyst to the oral mucosa. Okay, then because the cyst grows by volume expansion, so when you have created a window and you have sutured the lining of the cyst to the oral mucosa, the fluid that has been the fluid in the cyst will be draining out from time to time. As a result, the cyst lining will shrink. So that is what we call marsupialization. Enucleation is where you raise a flap, you create a window, then you remove the whole lining together. So you don't leave anything, you remove. Primary marsupialization is reserved for a very huge cyst. You marsupialize first, shrink the cyst, because once the cyst has started to shrink, the overlying bone will remodel. Okay, it will remodel. Then you can do your secondary enucleation, meaning you enucleate the remaining of the lining inside the cyst. Okay, inside the maxillary sinus. Okay, right. So this is buccal advanced bone flap. Okay, you can do a trapezoidal flap. Okay, raise a flap, and then you have to cut the periosteum. If you don't cut the periosteum, you cannot pull. You cannot advance the flap. Once you have advanced the flap, you suture the area. All right. Okay. This is again. You have a tooth there. Okay, that has been extracted, and there is a communication. Okay. You raise the flap, then you cut the periosteum, and then you advance the flap and close the communication. All right. But before you do anything, you need to de-epithelialize the fistula or the communication. You need to remove the surrounding mucosa. Right. Okay. Okay, this is what we call enucleation. Enucleation of the cyst. All right. You can raise a flap, remove part of the overlying bone, then you can enucleate the cyst. This is a cyst lining. Okay, what about trauma? Okay, for example, you have Lafort 1, Lafort 2 fracture. Okay, for trauma, you can treat the fracture either by close reduction, meaning you don't do surgery, you don't do open surgery, or you can do an open surgery, meaning you raise a flap, reduce the fracture, and fix the fracture with plate and screws. Okay, that is for trauma. For fibro-osseous lesion, fibro-osseous lesion, this is bony lesion, you can do a debulking surgery, meaning you have expansion of the tumor, you raise a flap, and then you use your surgical handpiece as a surgical drill, and you debulk the tumor, reduce the size of the tumor. You can recontour the tumor, or you can resect the whole tumor. Okay, whatever your decision, whatever your plan is depend on what type of pathology we are dealing with. Okay, if you are dealing with, for example, ameloblastoma, or you are dealing with squamous cell carcinoma, resection is a must. Ameloblastoma, why you need to resect? Because recurrent rate is very high, especially in the maxillary area. All right. For fibro-osseous lesion, this one, for example, ossifying fibroma, you can do either debulking or you can recontour it. Okay. For malignant lesion, for example, squamous cell carcinoma, you have to resect. Once you have resected the area, there will be a defect there, a major defect. It will be a big defect. So you have to reconstruct. So reconstruction, you can either use prosthesis or you can do surgical reconstruction. All right. So how to approach the tumor at the maxillary area? You can use a Weber-Ferguson technique. This is where you make a cut on the skin, on the overlying skin of the face, and you follow at the lateral aspect of the nose, split the lip, and then cut inside the mouth, and then you can flip over the flap. It's like you open a book. Okay. Once you raise the flap, you can see the tumor. Then you can make a resection, and then you can reconstruct the area. Okay. For insufficient bone height, for example, you want to place an implant. This is where you do bone grafting via a sinus lift procedure. All right. Okay, this is an example of a squamous cell carcinoma of the left maxillary region. This is one of the cases that I operated a few years back. Okay, you can see here I have resected the maxilla, a procedure known as maxillectomy. Okay, but before that, just to show you how we raise the flap, this is what we call Weber-Ferguson technique. You make a cut at the lateral aspect of the nose, you split the lip, and then you make a vestibular cut all the way from anterior to posterior. Then you raise the flap. This is the flap. So it's like it's like that you open a book here, so you can see the whole tumor here. All right. So this is the right maxillary area. Okay. This is a patient operated on the left side. Okay. So you can see here how the area has been resected. It's a big defect, so you have to reconstruct. Otherwise, patient cannot swallow. Patient cannot swallow because for a swallowing process, you need a palate. If there is no palate, how patient going to swallow? All right. So this is the flap via we raise the flap via a Weber-Ferguson approach. So you see, you make an incision at the infraorbital area, and then you follow the lateral aspect of the nose. Then you split the lip, and then you make a cut in the oral cavity. So you can raise a flap like you open a book. All right. Okay, this is for trauma. Okay, you have a fracture, for example, at Lefort 1 level, and then you have fracture at Lefort 2 level, pyramidal fracture, or Lefort 3 level, where the whole face is dissociated from the cranial base. All right. So you can fix the fracture site using a plate. Here, this is the infraorbital region. You see, this is the eye, which has been protected. Okay, this is the infraorbital region. You can see fracture here. Okay, we have reduced the fracture. Then we use plate and screw to fix the fracture. All right. This is how we fix the fracture at the piriform fossa and also at the posterior aspect of the maxilla. Okay, you can see plate here. We have reduced the fracture and then we put a plate here. Okay. And if you look at this illustration, this is how we plated the maxillary area. So maxillary area, this is the maxilla, and you have the maxillary sinus inside here. So if you don't reduce and fix the fracture, the lining of the maxillary sinus will be obliterated, and then you may have pathological changes. You may have polyp, you may have any other pathological formation as a result of untreated maxillary fracture. All right. So, in conclusion, the knowledge of anatomy of the maxillary sinus is very important. I'm stressing it's very important for every one of you. Okay. So you need to know in detail the anatomy of the sinus, how important the relationship of the root of the upper posterior teeth to the maxillary sinus, and what are the changes that can happen in the sinus when you have pathological changes, when you have trauma, when you have inflammatory, or when you have communication from oral cavity to the antrum, right? So it's very important for everyone to remember that. And so I hope by the end of this lecture, you have a clear idea of what is maxillary sinus, the relationship of the sinus to the surrounding structure, and how do we manage and how do we assess and manage any pathological or any any communication in between the sinus and the oral cavity. Okay, so these are my references. So if you have any query, if you have any question that you want to ask me, you can either message me, or I think Shamini has formed a group. I think OMFS group. So you can put out whatever question you want in the group, and then I will answer the question. Okay, because I won't be coming yet to PIDC at least until February next year. So I will only see you in February next year. So for the time being, we will be communicating either via WhatsApp or during Friday lectures. Okay, so I think that is all for today's. Are you still there?
Yes, Doctor. Doctor, can we
Alright.
just take one screenshot for the attendance purpose?
Okay.
Sure, sorry, Doctor. Thank you.
Okay, ready? I will take the screenshot. One. Okay, thank you.
Okay. All right. Thank you for your time. Sorry, I don't actually like to give lecture online because I've been giving lecture online. I mean, nationally and internationally. But seriously, I don't like giving lecture online because sometimes you have internet problem. Sometimes you cannot talk freely. For me, face-to-face interaction is even better. So maybe one of the day I will try to make my effort to come over, but since I'm still in the government service, but soon I will be retiring very soon. So maybe after that I will be able to come more frequent to PIDC and we have face-to-face lecture, which is better lah. Right? So you have a nice day, study hard, and then just run through my slides. If you have any question that you want to ask, remember you can always message me like what your colleague have done last time, your senior. They will give me so many questions and then I will answer to them. Some of them will call me personally, asking me about trauma, asking me about this, that. I mean, I'm happy to answer. No problem. You can always approach me. Okay? All right. Okay. So thank you very much. Have a nice day. See you again. Bye-bye.
Thank you, Doctor.
Thank you, Doctor.
Thank you.